Pelvic floor muscle is the floor for the big cavity including abdomen and pelvic cavity. When the abdominal cavity pressure increases like cough and sneeze, the pelvic floor muscle is challenged. Viewed from below, pelvic floor muscle cover practically the whole lower part of pelvic cavity except for the hiatus called levator hiatus. Through the hiatus, urethra, vagina, and anus do open externally. In diagonal view, pelvic floor is like a bowl except for the hiatus opening at the center of the front part. Thicker part of the muscle at the brim of the hiatus is called puborectalis muscle. Pelvic floor muscle support pelvic organs, bladder, uterus, and rectum above it. Puborectalis part also act as common sphincter to provide gripping function for the three systems. The healthy grip is essential for continence function of urine and feces and also for normal sexual function. When pelvic floor weakened, it is not only sag but also loosen the grip. The sagging bends the passage of defecation causes obstructive type defecation or obstructed defecation. Urinary incontinence is one of the problems occurs as a result of the loosening of the grip. Because of the bent passage, the person strains during bowel movement. Because of the weak pelvic floor support, it bends further to worsen the constipation, hence form a bad vicious cycle of constipation, straining, and pelvic floor sagging or descent. With this vicious cycle, the situation worsened. The chronic straining would push down airy organs. Cystocele is bladder prolapse into vagina. Uterus prolapse into vagina in stages. Rectocele when rectum prolapse into vagina. In more severe situations, fecal incontinence occur. In this situation, a person can have both fecal incontinence and constipation at the same time due to the overflow incontinence of feces. In extreme situation, rectum can also prolapse through anus and the whole uterus prolapse made through vagina. Let's have a holistic understanding to have clearer picture how they are interrelated. Constipation of whatever reason would lead to straining. Straining descends pelvic floor or perineum. Descended pelvic floor cause obstructed defecation or constipation. This forms vicious cycle to worsen the situation. Women suffer more pelvic floor problem because of pregnancy, birth trauma, menopause, and aging. Descended perineum cause overstretching and tear of anal mucosa, which is called anal fissure. Tear cause pain, and pain lead to spasm. Spasm cause constipation. This forms another vicious cycle to cause chronic anal fissure. Gold standard treatment of anal fissure, lateral internal sphincterotomy, involve cutting part of anal sphincter with risk of permanent anal incontinence aimed to relieve the spasm, but nothing to prevent future stretching at tear. That's why anal fissure also occur in those with loose anus. Descended perineum also cause exposure of anal mucosa, plus straining the hemorrhoidal vein in anal mucosa engorge to cause hemorrhoid. Surgery may just remove the hemorrhoid, but the cause of hemorrhoid, chronic straining during defecation, still remain. To cause recurrence even after successful surgery. Besides descent of pelvic floor, straining also stretch puborectalis and widening of levator hiatus. This gradually gives rise to wide range of pelvic floor disorder include urinary incontinence, sexual dysfunction, uterus prolapse, pudendal nerve stretching, and others. Urinary incontinence is only one of many manifestations of weakened of pelvic floor. This understanding clearly shows various pelvic floor disorders actually have common causative mechanism. They are all related to weakness of pelvic floor muscle and constipation. For better understanding, disease should be named after the cause, not the manifestation. Defecatory perineal disorder (DPD) refers to perineal disorders, which is closely associated with weakness of pelvic floor and chronic straining for defecation. These are known causes contributing to pelvic floor disorders. There are measures to control or manage these factors. To prevent damage of pelvic floor due to birth trauma, medical world has been routinely practicing perineal support when the baby's head is coming out through vaginal opening. To minimize the damage due to chronic straining during defecation, we take various measures to manage constipation. To manage problem due to weakened pelvic floor muscle, Kegel exercise is commonly recommended. Reconstructive surgery is recommended when the conservative approach failed. Aim to reconstruct the damaged pelvic floor support. Sling or mesh surgery is an example of reconstructive surgery. Carpal suspension is similar to sling surgery except for the fact it makes use of part of vaginal wall to hold up the sac urethra. For better understanding, let's put these interventions into the same DPT chart. For vaginal delivery, there is perineal support to prevent overstretching of pelvic floor. For various types of constipation, stool softeners is recommended to prevent straining, which is one of the causes of pelvic floor damage. For weakened pelvic floor, Kegel exercise is to strengthen the muscle. For urinary incontinence, there is sling surgery or carpal suspension to prevent descent of the affected part of pelvic floor. All of the approaches available are based on the same principle and targeting the same thing, which is to help the weakened pelvic floor support. But why the complication still occurs? Because we are yet to have sufficient understanding about the pelvic floor, and we are yet to understand fully why the complication occurs. Something important is missing. During defecation, pelvic floor together with pelvic organs descend even in normal person. This study show bladders descend by 3 cm. Another study show anus descend by 3 cm. In patients with urinary incontinence, their pelvic floor support weakened and their bladder descend. With sling surgery or carpal suspension, the urethra is lifted up to correct the urinary incontinence caused. During defecation, especially with straining, the pelvic floor together with pelvic organs will be pushed down further. At this time, the surgical site will be overloaded beyond physiological limit because the implanted artificial sling does not have the intelligence to descend as part of the reflex of defecation. This represents sling at ideal location. During defecation, urethra is pushed down towards the mesh. Initially may be reversible, gradually they get closer. It causes severe pain when mesh touches the nerve plexus. If not controlled, it may worsen and cut into urethra or bladder. In carpal suspension, urethra is lifted up by stitching part of vaginal wall. Similarly, the urethra migrate downwards as vaginal wall started to give way gradually. It is less likely to cause pain, but the surgery would eventually fail too. Now, we have better picture why surgery failed and complicated. Because straining is still there. There are still various factors to cause constipation. We cannot avoid aging. The bad vicious cycle of constipation, straining and pushing on the pelvic floor still there. Pelvic floor continues to descend and eventually fails the surgery and contribute to complication. This seems to be an important factor overlooked, leading to complication affecting every level of health system. Hundreds of thousands of women are in pain, the rest are in fear. Priority should always be best therapeutic outcome for the patients, as cost-effective and as conservative as possible, not which modality is better than the other. Is there any room for improvement? Evidence showed just with manual support on pelvic floor during bowel movement significantly is defecation process. If this is the problem, this should help. A mechanical option like this should also work. If defecation can be aided mechanically like this during aerial defecation, when pelvic floor strength is challenged the most, surgical site would be protected, pain should be less, and healing should be better. Refer back to the DPD chart again. Now, we have two additional options with same principle of helping the support system of pelvic floor. Both the manual and mechanical bowel aid deserve serious attention in management of pelvic floor and defecation related disorder (DPD), including management of mesh or sling associated complications. In this case report, a senior nurse who consented a sling surgery to fix her urinary incontinence problem in 2008, she started to have progressively worsening pain since 2011. 2 months later, with bowel-aided defecation, she started to experience pain reduction. 6 months after that, she reported pain-free. 1 year after regular practice of bowel-aided defecation, she regained her normal painless sexual intercourse. Today, end of 2017, she is 9 years after the sling surgery that associated with largest surgical complication, but she is pain-free since the past 4 years, enjoying painless sexual intercourse, and she is also enjoying the benefit of sling surgery, which keep her free from urinary incontinence. If this can help the nurse with mesh complication, logically it would have more promising preventive role for mesh patients who are yet to end up in complications. The holistic approach with bowel aid is actually found to benefit wide range of medical problems in DPD. In a control study, bowel aid versus the gold standard surgery, lateral internal sphincterotomy where the natural anal sphincter is partially weakened surgically. Bowel aid report to achieve 100% success rate in managing chronic anesthesia without any complication. In another study comparing bowel aid in study group versus hydrocortisone cream in the control arm, bowel aid significantly managed the otherwise problematic hemorrhoid in pregnancy without drug, without reproductive risk. This was done with bowel aid, a special toilet seat with additional support mean (HPS) to provide just an external supplementary pelvic floor support during defecation. It is beyond doubt that the root cause is weakened pelvic floor support. The solution comes in various forms with same aim to strengthen or protect pelvic floor support. In comparison, bowel aid may look very promising, but we should always remember there are still a factor none of the above options can manage effectively, that is aging. Main objective should not to prove which one is better. Instead, every option should be explored with priority for better therapeutic outcome to patient, as conservative as possible and as cost-effective as possible. Invasive and expensive surgery may have their role, but only to be considered after all the conservative options thoroughly explored. In management of osteoarthritis, walking aid play a very important role to delay total knee replacement. For those who really indicated for artificial knee, patient is fully equipped with information about their limitation and responsibility, how to prolong the lifespan of the artificial knee. Walking aid always come very handy. What would happen to orthopedic surgery if there is no walking aid in the world? History taught us importance of aids since ages before we discover medication and surgery. Bowel aid is just another medical aid. Hope with this info, women can now better equip with info of how to protect their natural pelvic floor, keeping surgery only to the last. And if they are really indicated for surgery, regardless of sling or carpal suspension, with the input, hopefully the surgery will last them for the rest of their life.